All right. Well, good evening, everyone. My name is Joshua Foray. I'm with the Maryland Academy of Family Physicians. I'm really happy to be here today to get us started for another one of our webinars that is a joint project between the MDAFP as well as MACHO, the Maryland Association of County Health Officers. We had a project, or we had a webinar a couple months ago. We're having another one today. We're working together for a few different reasons. Big ones were strengthening relationships between family physicians who are seeing patients every day, as well as local health departments and organizations who serve as the backbone of our public health. And really, these two are very strongly interrelated. We're also trying to support health equity, talk about social determinants of health and how we can integrate, addressing those and, checking for how those are affecting our patients every day, and finding different ways that we can collaborate between the public health side and the primary care, because again, everything is so related. This is part of our webinars. Again, we had one a few months ago that kind of just showed overall, how local health departments are helpful to us, certain ways that we as primary care physicians can gain some information about them. We have a few other ones. We have monthly articles that so the MDAFP has its monthly newsletter, and often we get input from MACHO on important current events and public health topics. And you can also access on the MDAFP website some information about common services available at local health departments as well. And we can always help you get in contact with county health officers, the local health departments, et cetera. Talking about today's project or today's webinar, this is going to be a focus on behavioral health. So, behavioral health, there is certainly a lot that happens importantly in primary care, but there are also other things that local health departments can play a role in, often under-recognized, but very important, related to prevention, harm reduction, helping with crisis situations. And I am going to go ahead and leave it to, well, actually, I should say our two speakers today. We've got Mina Brewster, who's the health officer of St. Mary's County, and then Gina Spear, who is the health officer at Allegheny County. And so I'm going to pass it off to Mina to go ahead and talk about what they're planning to discuss today.
Great. Thank you so much for introducing the PowerPoint presentation. And thanks everyone for who's tuning in today or who's watching this later as a recording. We really appreciate your time and your interest in identifying some potential opportunities for greater collaboration between primary care and the practice of public health at local levels. So we're going to focus on these 5 objectives today. To really hopefully talk a little bit about the behavioral health system kind of at a broader community level and discuss different components within that system and what our role is as local health departments and as chief health strategists around many topics, but specifically for this tonight's portion, talking about the behavioral health topic. And then lastly, really try to connect it all together. Like, what can you do as primary care clinicians to better connect your patients to behavioral health and wellness supports in your own local community, and some of the ways that you can get involved as a primary care clinician as well. Okay. For those of you who've joined us previously for one of the MDAFP MACHO joint webinars, we've talked a little bit about what the role of local health departments are in Maryland. Local health departments are, governmental entities whose mission is wholly about improving health outcomes for their whole community, their entire jurisdiction. And we do that in many different ways, and we touch upon many different health priority topics in our community. But through it all, our major role is to serve as our jurisdiction's chief health strategist. And that is, that's a phrase that's used nationally when describing the role of local health departments in every jurisdiction across the country. And in Maryland, I'm proud to say, I feel like we do a pretty comprehensive, we take a pretty comprehensive approach to health and wellness. We're not just focused on single item health issues. We really try to look at the whole person within the context of their whole community and the various sectors that influence health and wellness within a community. This is an example. This is a graphic that really illustrates for you what local health departments focus on. And some are these foundational areas or topic areas. And beneath that are what we call foundational capabilities. These are the kind of functions that we have, and we apply those functions to the foundational areas up top and really try to look at the overall health and wellness of a community over time. So just behavioral health is one core area that we in Maryland feel and approach, feel it's a core part of health, as I'm sure all of you do as well. And it is to us an important foundational area of local public health practice and what our role is as the community chief health strategist. And so the next slide actually talks a little bit more about how that role of chief health strategist applies to the topic of behavioral health. So a lot of the pictures you saw in the previous slide where I talked about, the different functions that local health departments have, there are different roles that we have as it applies to different health topic areas. We apply to behavioral health. So we are monitoring data in the community to try to figure out what are the behavioral health concerns within our community, what are the risk factors for those concerns, what are protective factors, how can we enhance the protective factors, how can we minimize risk factors for behavioral health outcomes. And we continually do that assessment and monitoring, communicate that data to our community partners and so forth. And a lot of other work as chief health strategists as it applies to the behavioral health topic. So really one key role of ours as local health departments is to convene partnerships and to leverage resources across sectors so that we can all collectively kind of move the needle towards better health outcomes in many different areas, including in behavioral health. And so we do an extraordinary amount of partnership engagement across sectors at local levels. And in that process, find ways for improved health outcomes to be meaningful to those different sectors. So it's not just about the healthcare providers and public health partners who are fully vested in improved health and well-being. These are very relevant outcomes and desirable goals for the economic sectors, for public housing, for education, et cetera. And we're able to get those partners fully engaged in some of this collaborative work. One key role in this is to always be looking at what kind of access to care our community members have. And is that access to care adequate across different types of healthcare services? What type of barriers might there be to access to care? Not just shortage of healthcare clinicians, but also barriers like transportation, affordability, language barriers, et cetera. And so how do we, and how we as a community can then address some of those barriers or ramp up some of those healthcare services for different areas of need in our county. And so that is something, and we'll talk about that a little bit further, but that is a key role of applying the chief health strategist function to behavioral health, is really looking at the system of behavioral health care, identifying gaps and finding ways to hopefully fill in some of those gaps so we have better access to behavioral health care. Alongside, on the other side of this slide here are some examples of public health interventions that we typically do in the behavioral health space. Many local health departments throughout Maryland, all of us do at least some of these. Some of us do all of these. And so it kind of varies jurisdiction by jurisdiction, depending on what the local needs are and what resources we may have to address those needs. But we pretty much all consistently at the local health department level are implementing many of these public health interventions in our quest to improve behavioral health for our community. So one of the questions that often comes up about management of behavioral health is, what is the role of the local health department, and what is the local behavioral health authority? What is that? And what is their role? Is that where I go to make complaints about a particular behavioral health provider? Is that where I go to get licensed as a behavioral health therapist? So there's all these questions about what is this local behavioral health authority? Essentially, the local behavioral health authority is something that's been set up in Maryland statute as an extension of the state health department's responsibility towards the public behavioral health system. So let me explain that a little bit further. So your public behavioral health system are essentially your behavioral health treatment system or providers and practices that are receiving funding through through public funds, right? That's traditionally managed like Medicaid. And there's an administrative services organization, or ASO, that helps get those public funds administered to providers who are billing for those services. And so I think, what the role of the local behavioral health authority is really to be local system managers of that public behavioral health system. So all of the clinical entities and providers that provide behavioral health services locally and that utilize the public behavioral health system, they work through the administrative services organization to get paid for the services they provide to community members. Those entities and providers will inevitably interact with the local behavioral health authority. And the local behavioral health authority works with them to ensure that they are engaged, that patients are able to access their services. If there are complaints about them, that some of that complaint may get to the doorstep of the local behavioral health authority to look into, along with the state and looking into potential complaints. And the LBHA may facilitate certain services or referrals within that public behavioral health system when there's a significant limited supply. But one of the key roles that the local behavioral health authority has in being those local system managers is to identify what is all the availability of services within that public behavioral health system, from treatment to rehab, all the kinds of kind of clinical support services that are necessary for that public behavioral health system to function well and comprehensively. And that LBHA then works to try to, again, fill in some of those gaps in that system. So it's a bit of a mixed bag in Maryland in terms of how LBHAs are structured relative to their local health departments. Certainly the local health department has a chief health strategist role. It is very comprehensive in its approach towards health and wellness. And, we all, as local health departments, definitely see behavioral health within our domain of health and wellness, right? We don't want to split out behavioral health from the rest of health when we talk about community wellness. And so we are very engaged on that topic, even if the LBHA is not part of our health department. In many jurisdictions, the local behavioral health authority is part of the local health department. And so then there's really great syncing up of effort. We really do a great job, I think, in that type of model and applying the public health lens to all kinds of behavioral health topics. In some jurisdictions, the local behavioral health authority is partially within the health department, and that's because before they were LBHAs, there were two separate entities. There was one focused on mental health and one focused on addictions. And at some point, the state merged it to be calling it a local behavioral health authority. But in some jurisdictions, those two entities still retained their separate identities. And in some jurisdictions, one of the two separate identities is in the local health department and the other of the two is not. And so that's where you see that Venn diagram there, where there's only partial overlap. And then there are a few jurisdictions where the LBHA is completely separate from the local health department, and it may exist as a nonprofit entity or some kind of, it could be a government entity. I mean, there are different models in different jurisdictions. I'm going to pass it over to Gina Spear from Allegheny County to talk about what her health department does. They're just a phenomenal model in the state of a local health department that delivers direct behavioral health clinical services. So I know she has a lot to share.
Thank you, Mina, for those wonderful words. We do provide a lot of direct behavioral health services, and that is mainly because we are in a health professional shortage area and we have problems in the rural communities recruiting and retaining professionals in our area. We also, with the public behavioral health services, we normally, a lot of our clientele are Medicaid eligible, and with Allegheny County being a high poverty rate and with a high percentage of patients eligible for Medicaid, we end up treating a lot of them. So I'm going to talk a little bit about our outpatient services, our inpatient services. We have special initiatives that we work on, and then what happens beyond the treatment? How do we provide preventive services? So first of all, we operate in outpatient mental health center. It's part of our outpatient behavioral health services. We provide individuals therapy for individuals, group, and family therapy for ages 3 and up. We have school-based counseling services. I saw Joshua's expression there. I might go a little bit into the 3 and up. We have a lot of children who are born to addicted parents, and there's a lot of behavioral health issues from very early age. So we have what you call a kids intensive day services. We call it kids, where we have children that come in from the school system, children that have either been expelled from public school or in danger of being expelled from public school. They are on a home and hospital waiver, and they come to our clinic. They're for children ages 6 through 12. So we provide intensive services for them at a minimum of 9 hours per week, but a lot of times more because we keep them 5 days a week. When they're finished with their treatment, they go back into the schools, and then we provide education to the teachers on how to deal with behavioral health problems. That program has been growing smaller because there are actually a lot of behavioral health services that are located within the school system now. So we're getting fewer and fewer referrals, which is a good thing. We are going to be transitioning that program to a TOTS program because we are having more issues with what our director of student services calls the littles, which are ages 3 through 5. So starting next school year, we're working on a school-based therapy program for TOTS, Toddlers Outpatient Treatment Services. So they will be focused on 3 to 5 age group, and will also provide family counseling and family education on how to deal with emotional problems. So in addition to that, we have our school-based counseling services. We have social workers, LCPCs out in the schools to help the school system treat their students. We provide medication evaluation and management on an outpatient basis. And we have a clausural clinic for patients with treatment-resistant schizophrenia. On our outpatient substance use disorder program, or SUD program, we provide services for adolescents and adults. We provide peer support services and counseling, gambling evaluation and treatment. We have a DWI education program where an individual may be ordered from the Motor Vehicle Administration or a judge to have educational services. That's required 2 hours a week for 6 weeks. So it's a total of 12 hours of education, and they must attend all 12 hours of education for them to get a pass and for them to be able to drive again. We provide medications for opioid and alcohol use disorder, MOUD and MAUD. We have a buprenorphine program where we have patients come in. We'll do buprenorphine induction. We'll provide them with counseling and treatment. And we have a pregnant and parenting women program where we provide evaluation and referrals to residential treatment for those individuals. We also have an outpatient residential treatment services program, otherwise known as a halfway house. We call it the Allegheny House. And this is for residential services for clients that are early in their recovery. The residents stay in the house for a period of 3 to 6 months, and then they continue their treatment that they were receiving at an inpatient facility on an outpatient basis. And this can include MOUD and MAUD. We provide transportation to AA and NA groups. We provide peer support services, and we assist them in finding a job and obtaining transportation to that job. We run an inpatient residential substance use treatment center. We are one of 2 state-run programs in Maryland. Our catchment area is the National Capital Region West, and then we have a sister agency. It's in Kent County called the AF Whitsitt Center that provides services from the National Capital Area East. We will take patients from all over the state, and we have actually taken patients from outside of the state as well. So the Joseph Massey unit provides withdrawal management, individual, group, and family therapy, individualized care, including care for pregnant women, people with gender identity issues, wound care, birth control. So we provide individual care. Each of our patients have an individual treatment plan. We provide alcohol and substance use education, peer services, MOUD, MAUD, medical care. We have a board certified psychiatrist who would provide psychiatric evaluation and medication management. And this individual is also certified in addictions medicine. And then we also provide aftercare services for these individuals. So our special initiatives, we have initiatives that are not essentially direct care services, but they are initiatives to help us work with our community. So we participate in drug court. We have a social worker that goes to drug court, provides advice to the judges and the clients, offers treatment services in lieu of incarceration. We do the same thing with a mental health court. We have a licensed social worker will go to the mental health court, provide consultation services for the individuals, and we will offer treatment on an outpatient basis in lieu of incarceration. We have a jail substance abuse program. 85% of the people in jail are in there because of substance use disorder or substance use disorder related crimes. We provide Maryland Community Criminal Justice Treatment Program, MCCJTP, and that is case management services for people with substance use disorder, serious mental illness that are leaving incarceration and going back into the community. We have a community forensic aftercare program. That is a program that monitors and evaluates patients that have been discharged from a state psychiatric facility that are on a conditional release. And those individuals need monitoring and care, make sure that they adhere to their medication and their treatment regimen. We have a crisis intervention team training program that trains law enforcement officers on crisis intervention, de-escalation. It brings together behavioral health specialists in the community and people with lived experiences to try and de-escalate mental health crises that might happen in the community. We have projects for assistance in transition from homelessness, our PATH program, and it helps adults and children who are experiencing homelessness with rental assistance and an ability to get into some housing. We have a continuum of care program is also case management, our state care coordination, suicide prevention initiative. We provide gun locks and gun safes and lethal means education. And then we have mental health first aid training. Those are some of our special initiatives. Beyond our treatment, we also do prevention and harm reduction. So we have an overdose prevention and mental health resources. I have some live links in the slides. Prescribed Change Allegheny gives you resources for education, how to speak to your children about drugs and various information, and Mental Health Matters. That's also a live link if you want some education materials there. We provide then life skills in our elementary schools, which is just basic critical general education, critical thinking, prevention or Project Alert in our middle schools, which includes substance use prevention, and then prevention and wellness that actually occur during the school day. The Bothan Life Skills and Project Alert is a voluntary program for after school activities that parents can enroll their children in. The prevention and wellness is actually a program that is incorporated into the health classes in the school system and also the gym classes in the school system. So of course the parents can opt out if they don't want their children to take it, but it's a substance abuse prevention program. We are in discussions with one of our high school to start a pilot on a peer support program for high school students who are interested in this field and are interested in substance abuse prevention and have seen some of their friends overdose and have some experience to speak out about prevention and help with training on a peer level. That we are in talks with the school system. It's not quite up and running yet, but we're working on it. We also provide naloxone training that are free to the schools, the community, and businesses. We have a prescription drug take-back program that operates in conjunction with local law enforcement. We have 5 drop-off boxes at various places throughout the community. Local law enforcement will provide many take-back events where you can come and give unused prescription drugs to them. And then if you are homebound, we'll actually schedule a pickup to go to your home and pick up unused drugs. We have recently, since the new law from legalizing cannabis, we now have a cannabis awareness and education program to talk about that. Our syringe services are provided by our partner, AHEC West. So we have a syringe exchange program, but we're also part of the rapid analysis of drugs program. So we send those syringes to NIST to be analyzed for what is actually in them so that we can tell what type of illicit drugs are coming into our community, and so we know better how to respond to those. They also test drugs, and AHEC West is partnered with the school system to test the confiscated vape pens with the school resource officers. Anytime we have a vape pen that's confiscated in our school system, it goes to AHEC West and they send it for a rapid analysis of drugs. We have, I believe at one point we had found cocaine in a vape pen. So it doesn't happen very often, but we are able to identify what is in those pens and then address the issues. We have 4 naloxone vending machines located throughout the county. My PIO has put a picture of one of ours there. It has our Prescribed Change website on the side of it, so people can go to that website and get information and education about substance use disorders. We also have several newspaper boxes, and we strategically locate those throughout the county in either high traffic areas or areas that are known to have high overdose issues. We have reduced our overdoses over the last 2 years by close to 5%, and I believe part of that is not only our education around substance use disorders, but also making naloxone widely available, and also training for naloxone widely available. And the final thing we have for our treatment is we distribute test strips for xylazine, fentanyl, medetomidine, and benzodiazepines, so that if our injection drug users can test the drugs before they inject and determine whether or not it would be safe to inject or if it has been adulterated with a contaminant. Thank you, and back to Mina. Thank you.
Thank you. And, thanks, Gina. I feel like, Allegheny County Health Department and of course your host of partners in Western Maryland do such a great job with filling in those access to care gaps in your region. And I just, for everybody who's watching or listening, I mean, this is just such a great example of how local gets it done and really how local comes together, and typically it's the chief health strategist of the local health department kind of convening those partners and really just works together to figure out how do we address some of these gaps. And like we'll talk about later, this is where we're really relying upon our primary care partners. And those of you who are primary care clinicians and are seeing individuals and their families every day, you have an incredible wealth of knowledge and also direct experience with people and the and their families and the barriers that they face in accessing care. And so bringing that knowledge, bringing your experience to the conversation, working with your local health departments and other partners locally to figure out what solutions are needed and how to get those implemented. I mean, that's tremendous. And I hope every one of you gets a chance to figure out who the local health department is in your jurisdiction and finds a way to connect with your local health officer or other leadership at your health department. So Gina talked quite a bit about this amazing array of both direct clinical behavioral health services and inpatient and outpatient settings, but also about a variety of strategies that are being implemented at local levels, both through health departments and their community partners to prevent fatalities related to substance use and mental health concerns, to prevent complications and other harms associated with behavioral health concerns, and then certainly, hopefully, to even prevent the development of substance use patterns or to mitigate development of mental health concerns. And that span of services, all those interventions, while they may look a little different from jurisdiction to jurisdiction across the state, many of your jurisdictions are doing a variety of those types of things. And so if you are looking for how to get your patients connected, start with your public health partners and really kind of join those groups where people are planning things for the community. And you'll find out through those mechanisms and others that we'll talk about a little later on how to get your patients connected. What I wanted to do next is to highlight a couple specific areas that we thought it was really important for our local family docs and other primary care clinicians to know about. And one is this model called the Sequential Intercept Model, because pretty much every jurisdiction in the state is looking at this model and determining what they need to develop to address the different points of intersect. And I'll talk about that in a moment. And then the second piece that I really wanted to highlight is your local behavioral health crisis continuum of services. And there's different elements to that, and I'll highlight some of that. So let's start with the Sequential Intercept Model. This is essentially something that was developed some decades ago to really describe how a person may intersect with the criminal justice system, and talks about the interventions that can be helpful when the reason for their intersect with the criminal justice system or intersect with the criminal justice system, when the reason for that is tied to underlying substance use or tied to underlying mental health concerns. And that if we ignore those contributing factors of substance use disorder, of mental health or mental health illness, then we really run the risk of having individuals who really just need help, treatment, health, stabilized, other things addressed in their life so they can focus on their health, and instead these individuals may be connecting with the criminal justice system and going in and out of the courts, going in and out of detention centers and prisons, and there may be associated crime that the community is impacted by. So it's in everyone's benefit. It's in the benefit of health and wellness and community health. It's in the benefit of public safety for a community, and it's in the benefit of taxpayer dollars for not to have these constant points of contact with the criminal justice system. And so because of all of that, this is a really great example in communities of where health and public health work closely with law enforcement and public safety and criminal justice system, including courts and detention centers. And it is a really nice way to, in a community, look at what you have and make sure you're touching all of these potential points, and you're potentially diverting people from having to engage with the criminal justice system and getting them into what they really need, which might be treatment or some other stabilization. And so that's the concept behind this model. There's essentially 6 points of intercept that are noted here, starting with intercept 0. And the reason why it's 0 is because it's about prevention. It's about before you intercept or intersect with the criminal justice system. And then these other points of intercept are where they may already be some point of contact with the criminal justice system. And what we're trying to do is to keep them from going through that system and by getting them into appropriate treatment, or where we're keeping them from recidivism. We're kind of breaking the cycle of people staying in that system and kind of cycling in and out. So the first intercept 0 is really about, like I said, prevention. How do we keep them out of having any contact with the criminal justice system? And that is in large part what's already happening in the community, but bolstering it and doing a better job at identifying concerns with substance use and mental health before there may be some associated sequelae of those issues. And all these community prevention strategies, some of which Dina highlighted, your work in primary care is a critical piece of this, SBIRT and all of the screening and evaluations that you might be doing in primary care settings to identify concerns. And then also making sure that we have available crisis care services. And that is something I'll talk about after this, so that people don't have to show up in emergency departments because they have a more appropriate place for care. People don't have to, maybe they turn to crime because they're trying to get the money to buy a drug that they're addicted to, and so forth. And so this, getting appropriate care for those issues can help prevent that engagement with the system. And there's a variety of other types of, I'm not going to read through all of these, but you can see that there are a variety of other places of engagement in the criminal justice system, from when there's first some type of infraction and there's some engagement with law enforcement. There's an opportunity to have what's called a law enforcement assisted diversion program, or LEAD, at that intercept 1 level, where rather than giving somebody a criminal citation or some kind of civil citation, depending on what it is, that the officer, before filing all of that, gives the option of getting a person connected to treatment and maybe working with a peer recovery coach or a care coordinator to ensure that they're moving through that treatment option. Another really good intervention that has had wonderful success in many different communities is what's called a co-responder model, or a model essentially where it's not just law enforcement responding to something that might have some kind of behavioral health issue involved. That maybe it's law enforcement paired with a peer recovery coach who's walked the experience of substance use in the past and really understands it and can empathize really well with individuals who may be in some kind of crisis. Or maybe it's a behavioral health counselor or therapist or some clinician who accompanies law enforcement to that response out in the field. And so these types of arrangements can be really meaningful and can give an opportunity to get people connected to treatment instead of going further through the criminal justice system. Another point of Intersect is Intercept 2. And I know where I am in St. Mary's County in Southern Maryland, our law enforcement locally does a lot of work in this area. And we're one of the first communities in the state to offer pretrial services. So before, somebody might be initially booked after committing some kind of crime or they're waiting for their hearing. And in that waiting period of time, they may be supported with care coordination, and they may even get evaluation and treatment and demonstrate that they're really trying. And that makes a difference when they then go in front of the judge and are assessed. And so there's a variety of things in that level as well. Some ideas that I've listed here. Intercept 3 is when you're actually involved with the jails and the courts. And in a lot of jurisdictions in Maryland, we have what's called problem-solving courts, where if a crime is related to underlying substance use or, typically a substance use problem-solving court, then a person is surrounded with, or is given the option of participating in the specialized problem-solving court. They get care coordination, they get connected to treatment. They demonstrate ongoing treatment as they're going through this court, and they graduate essentially from it. And that has an impact on the heaviness of their sentence or the judgment that comes associated with whatever crime was involved. And it's really important in this Intercept to offer treatment in jails, including medication-assisted treatment. And that's something Maryland has really kind of stepped forward with trying to ensure is happening in all detention centers across the state. And that helps ensure that individuals who have underlying substance use disorder continue to receive treatment. And hopefully, as we get to Intercept 4, that their re-entry back in the community when they're released from detention or from incarceration gets them reconnected to ongoing treatment. So there's no lapse in their treatment. And then, you don't want to lapse because there's a risk, of course, of overdose or other issues in that time period. And really Intercept 4 is important because it's the first 2 weeks upon release from incarceration that traditionally carry the highest risk of fatal overdose and death by suicide, because that's when people haven't been reconnected to ongoing treatment, medications, whatever it is. They may have lost their health benefits during their detention. And then when they get out, and there may be a lapse in getting those health benefits back, and they're not engaging with the medical care they might need. And so it's such a high risk period of time. They might have unstable housing during that period of time. There's a lot going on. And so that work around Intercept 4 is really important to make sure people have safe reentry into the community. And then lastly, Intercept 5 talks about programs that are available as people have recently left, and that 6, 9, 12 months after incarceration, that they get the support they need during their parole and probation period of time, so that they get truly connected with all the support services and health services that they need, and they can stay out of a future engagement with the criminal justice system. So that model is a really great one. It's one, like I said, that communities are using to help plan out what services are available in their local jurisdiction. The next slide goes more into the crisis response continuum of care. And Gina talked a bit about what they're doing in Allegheny County. And this is something that statewide, we're really trying to make sure that every Marylander has access to a comprehensive crisis response continuum of care. This is really hard to do when you have a tremendous shortage of behavioral health clinicians and psychiatrists and psychiatric nurse practitioners. And it's just really hard, especially in areas like ours, in more rural areas of the state, where it's even harder to recruit that limited supply. And so we really, are trying to ensure as best as we can with those limitations and of course restricted resources, that these services are available. It starts with, 3 essential core concepts to that continuum of care: is someone to talk to, someone who responds, and a place to go. And the someone to talk to is really that crisis hotline, and the 988, and how the 988 is handled in many ways in like regional call centers that are familiar with some of the local regional types of resources. And it can move forward to having a mobile crisis response, kind of similar to that co-responder model that I was describing before, but there's other kinds of mobile crisis response teams that are available, and different jurisdictions may have different time of that mobile crisis response. And so really kind of meeting somebody in the community or wherever they're located and trying to stabilize that crisis in that location, so it doesn't end up in the emergency department, so it doesn't end up in a detention center. And then having options for people to go to, and that's the place to go. And then, of course, after the crisis, making sure that we have all these amazing community supports in place to mitigate and prevent the next crisis. So let's go and explore that crisis stabilization options, a place to go, a little further in the next slide. So there are different ways to describe it. This is one example that an organization kind of categorized. What are the different types of crisis places to go, right, for crisis response that are appropriate for behavioral health, that are intended for behavioral health crises. You'll have different levels of this in most of our jurisdictions in the state. Most of our jurisdictions in the state would love to offer all of this, right? But again, because of the significant shortages that we have and the restriction in resources and just, it is really challenging because behavioral health has been splintered away from, the rest of the healthcare delivery system. So it hasn't had the attention. And, we also have a lot of, unfortunately, stigma in our community that has prevented us from, I think, adequately addressing behavioral health over decades. And so we're kind of playing catch up here, but many of us are working on making sure that our communities are trying to rev up places to go. And these are some examples. In St. Mary's County, for example, we have crisis walk-in services, which would be really kind of in that number two column. And we'd love to move to something further if we could recruit the healthcare providers that are needed to make that available. We also work with partners to ensure that there are crisis residential beds available to our community, even if not in our community. And there are some other of these services kind of popping up and developing in the Southern Maryland region like they are around the state. And then I'm going to end with this and pass the baton to Gina, who's going to wrap us up. A key part, and Gina talked about this quite a bit, that a key part of what we do in local communities is addressing health and wellness as in a comprehensive way, right? That it's not just about, the physiology of this or this single disease state and so forth, that we really want to, just like in family medicine, in public health, we're looking at the whole community, just like family medicine is looking at the whole person. And we want to, value the context of community and how there are many influences in a person's life that are influencing their health status, even if those factors are not medical in nature. And so addressing social needs and those kind of non-medical determinants of health or social determinants of health, however you'd like to call it. There's a lot of stuff that's going on in different jurisdictions. These are examples of some of the things that we're doing in St. Mary's County, where we offer a community directory of services electronically that everybody can access, and have maintained for our community a closed loop referral system as well. We do social needs screening through this community directory of services. and offer, as a health department, and certainly some of our collaborating organizations, offer care coordination and peer recovery coaching supports to our community members. So this is one way that our local clinicians can really engage and get access to these services for their patients, is through this electronic referral system that we've set up of a whole host of social needs services and health and wellness type services. I'm going to pass it to Gina. I know she's going to wrap us up. And actually, I'm going to skip over the next slide, but that was just more an example from St. Mary's County, which is our health hub, and it addresses a variety of behavioral health crisis walk-in services at the same time as it addresses a lot of these social needs in the same facility, or very closely, connected through our what I call our digital connective tissue of our electronic closed loop referral system.
Thank you. I just wanted to say that, as one of the other slides, this is a little bit out of order than what I was expecting. We're not just the service providers. We convene our community. We conduct community health needs assessments by convening our local partners, our physicians, our community. We do focus groups to determine what the needs of our community are. And then we also participate in coalitions like our Local Health Improvement Coalition, which is a variety of partners to discuss our problems, identify needs, and then determine strategies on how we're going to address it. So I just want to let you know to please reach out to us, reach out to your local health officer if you have a complex SUD case or mental illness case. We have providers that can help walk you through that, can help consult with you and get your patients the services that they need. And look forward to having a stronger partnership with primary health and local health departments. I really believe that we can help each other out and just help each other as with our different professions. So we are available for questions if anybody has any questions.
I can start. First, I wanted to say that there were a lot more in terms of mental health, like adjacent or related support, that wasn't specifically the behavioral health issue or the mental health issue, but other things that are all interconnected with it. So I really appreciated that you're able to support the people going through that in multiple ways. One question I had, Gina, for what you had with the naloxone vending machines, how much does that cost someone to get one of those?
We purchased the machines probably about 3 or 4 years ago.
I should clarify. Sorry, for someone like out on the streets when they use the vending machine, like do they have to put
free.
in? Oh, it's free. Okay,
It's
so
free.
they can just get one.
It's free. We keep them stocked with naloxone, and a couple of our newer ones we actually keep stocked with wound care kits as well, so they can prevent the overdose and then also take care of themselves if they have a related injury. So naloxone is free. We hand it out free at our health department. I'm sure all the other health departments do too. And then we provide free training. Our goal is to get that naloxone flooded into our community to prevent overdose deaths. So
Okay,
it doesn't cost anybody anything.
We move to our resources page. So here on the MACHO side, you can see there's a website that talks about the local health departments. Links to the different websites for the MDAFP. You can find various resources. Through YouTube, you can find some things, but also if you go directly to the MDAFP website, we've got a resources dashboard that we've worked on with MACHO that has the various links to the websites for the local health departments, as well as list a lot of the common services. I really want to thank Mina and Gina for talking tonight. Of course, Ruth and Madeline for helping to set up this webinar tonight. Thank you to those who joined us for the live webinar, but I believe we'll also have this available for people who didn't get to join us live to see the recording later on. Any other thoughts, Mina or Gina?
Yeah, just definitely wanted to thank you and just really MDAFP for everything. And I see Dr. Rouse on as well. Thank you to her for her leadership. And just, you know, I as a family doc and somebody who's been practicing public health now for probably over a couple of decades now. I just loved this partnership, and I love seeing how family physicians are still and passionate about engaging in their community and improving overall community. I mean, part of what drew me to family medicine, the main thing that drew me to family medicine and being a family doc was, you know, taking care of your patients within the context of their families and their communities. And so this is, I think this partnership is a really great collaborative venture. So thanks to all of you involved.
Yes, I want to thank you also, although I'm not as elegant as Mina. She basically said all of my thoughts. I'll just leave it there.
Very good. Well, thank you everyone for joining us, and I hope you have a good rest of your night.
Thank you so much.